Hello, everybody. I'm Dr. Bill Curry. I'm a general internist here at UAB, a past president of the Medical Association. I'm currently the governor of the state ACP. So I'm really excited to have my friend and colleague, Dr. Mike Saag, with us today. Mike is an international expert in infectious diseases, did a lot of work in HIV that would take all day to describe, and also in Hep C, and now is very much an expert in this disease. So Mike, welcome. Thanks for joining us.
Thanks, Bill. Good to be here.
So, Mike, you have the dual authority of an infectious disease expert and a victim of COVID, SARS-2-19. So, tell us what it's like to have this disease. How did you come to have it, and what's it like?
I can tell you this for sure. Nobody wants to get it. The disease, the best I can describe it is I would call it Groundhog's Day, because every day is almost the same. I started off with symptoms a few weeks ago. I picked this up driving back from New York with my son, who's also a physician. When we got to Birmingham, he said he didn't feel right and had some fever. And we looked at each other and said, okay, I think we've got this. We quarantined ourselves in our house, and I started developing symptoms the next day. It was mostly just a dry cough, a little bit of headache, fatigue, malaise, but it wasn't too bad. It progressed a little bit over the next 3 to 4 days. We both got tested on a Monday after getting back on a Friday, and we both tested positive. By Wednesday of that week, he was clear, and I thought I was going to be clear, and that's when Groundhog Day started. It basically was every night, starting about 4 to 6 p.m., I would get shaking chills, I'd spike a fever, and in essence have a cytokine storm. Headache, couldn't get comfortable, couldn't sleep at night. And for all of us who have ever been on call, right, as a resident, we each have had those really bad nights where we just are praying for the morning to arrive. And that's kind of how I felt every night for 8 nights in a row. The thing was that I never got short of breath to the point where I ever worried about an oxygen requirement. And I had a pulse ox at home and never got below 90. But the concern, knowing every night that I could go south from day 8 to 13 of illness was pretty awful. From day 8 to 13 of illness was pretty awful. And I wouldn't wish this on anyone. As everyone knows, once someone gets infected with SARS-CoV-2 or the COVID-19 virus, one of several things can happen. For about 20 to 30% of people, they're asymptomatic and they don't know it. For about another 40, 50%, they develop symptoms like I did, but they never go to the hospital. And the average length of illness is about 14 days. And then for that unfortunate 20% of people, they get hypoxemic and end up going to the hospital. And up to half of them, once they go in the hospital, maybe a little less than that, will develop respiratory failure and go on a ventilator. The problem is that our treatments right now are just symptomatic. We are trying to just control the symptoms.
All right, I want to get into the treatments in just a little bit. Let me ask you just a little more about your symptoms, because it's so fascinating to hear about it. Did you lose your taste? Did you have the agousia?
Right, I was going to mention that. So it's actually smell. Yeah. And then, of course, if we lose smell, then we lose taste. Yes. And as I've been reading more about this, that's almost universal. Not completely, but it's very pathognomonic. So that's a great question to ask a patient if you suspect they have a COVID-19, to say, how are you able to smell normally?
Right. And you said you had this couldn't get comfortable feeling, the cytokine feeling. Did you have like the creepy skin allodynia kind of feeling?
I did have a very strong sense of dysesthesias on my scalp.
Yeah.
And it felt like it was on fire, and it was just hard to. It was very sensitive to touch.
What was the character quality of your cough? What was that like? How prominent was it? What was it like?
It varied, and again, it sort of waxed and waned, that sort of Groundhog Day feature. It was mostly non-productive. However, when I forced myself to cough, I could produce sputum, and it usually had red flecks of blood. It wasn't true hemoptysis, like where you're coughing up a lot of blood, but it definitely was blood-streaked sputum, and that was a little scary.
Yeah, all right. Well, but we'll talk about treatment in a minute, but just to be sure everybody's got this straight, you know, the mortality rate is relatively low. It's higher than influenza. The infectivity of this is very high, more so than influenza. But if there's anybody out there that's wondering, is this something we need to take seriously, as opposed to, well, you know, people die of influenza. We hear all of that, 30 to 60,000 deaths a year from influenza. What would you say if there's somebody who's still a little skeptical about whether they need to take this really seriously as a practicing physician?
Yes, I think there's several key points. Number one, as you alluded to, it's very, very contagious. I would put it on the order of the common cold. Those are both coronaviruses. This is very easy to pick up. So even doing all the things that I knew to do, we kept our distance as best we could in the car. I washed my hands frequently. We wiped down steering wheels. And despite that, I got infected. So there is no substitute for staying at home and only going out for essentials. Secondly, we know that there could be a spike in cases, and that's critical for several reasons. One, it ultimately will lead to more deaths, but it also has the enormous potential to overwhelm our healthcare systems. We only have in our state so many ICU beds, and if we get overloaded all of a sudden with COVID cases in the hospital, and a lot of them end up in the ICU, it's going to consume our resources, but it'll also take up all the ICU beds. That's bad for at least two reasons. One, the COVID patients may not be able to get in, and Italy had to triage, actually taking people off a ventilator who they didn't think would survive to put someone else on because of the just the triage effect. And the second thing to keep in mind is those ICU beds are there for other kind of reasons. So somebody can have a heart attack or might have a burn or an accident and need to go into that unit, and there won't be a unit bed for them. So we need to take it seriously from that perspective. And finally, the numbers and the correlation to flu, to me, really don't add up for a couple of reasons. One, this is a brand new pandemic. No one has immunity to it. So everyone who experiences the infection is going to be developing our own natural immunity, and that's a little dangerous. And number two, we can't really control the spread of this unless we take it very, very seriously. To me, this is calling on all of us to be patriots, all of us to do our part as citizens, protecting our family and ourselves, but also protecting our community. We've never experienced anything like this. It's hard to relate, but we need to take very seriously the charge, not just as physicians and as physician leaders. We need to take this to the community, but also to let people know. A key statistic: every day that we delay implementing social distancing and staying at home, every day 40% more transmissions occur, 40%. So you can see by waiting just a couple of weeks, we expose our entire community to many, many, many more cases exponentially. So we finally have adopted this statewide. In Birmingham and in Jefferson County, we adopted it almost 3 weeks ago. I'm very proud of them. And some other cities and counties did that as well. But for the rest of us in the state, take this seriously. Governor Avi put the restrictions in last Friday night. Great. Now we can move forward. But we have to be leaders in this. We have to be patriots and change our behavior for the short term at least.
Well said. So one number that I've looked at is if you get to the point where we had last November 100 influenza cases in America. In 3 weeks, we had 700 or 800 cases of influenza in America. If you take the point where we had 100 COVID-19 cases in America, in 3 weeks, we had 25,000 cases.
Correct.
Of COVID-19. So that's kind of escalation. So just a bit about treatment. Obviously, there is all the symptomatic treatment, but there's more and more back and forth and controversy about hydroxychloroquine, chloroquine, azithromycin. There is obviously remdesivir, and there are other antivirals. Give us a little overlay about how should a practicing doc out here in Alabama be thinking about treatment, both in the ambulatory setting and in the hospital?
We should really be thinking about this in terms of clinical trials. we don't know if Plaquenil, hydroxychloroquine, with or without azithromycin really work. When you look at the data, the thing that got people very excited was a study out of France about 3 weeks ago where they took 20 patients, that's all, 20 patients, and they compared them to 16 controls and looked solely at the speed with which the virus cleared. And for those 20 patients, 6 of them got hydroxychloroquine with azithromycin, and they saw that as far as this relatively, actually very small sample size, that they cleared more quickly. That generated an enormous amount of enthusiasm to the point where providers and patients were running into the pharmacies asking for hydroxychloroquine almost to take as a prophylaxis. There are no data from a randomized trial yet to support the use of hydroxychloroquine with or without azithromycin. So the number 1, 2, 3 thing to do is to get them into a clinical trial. If someone's in the hospital and you don't have a lot of choice, then perhaps you might use it. I took it because I got symptoms at the time when the study came out, and several people advised me to. I got to tell you, I don't think it did a thing to help me. I can't say it made me worse, but I was concerned every day about whether my QTC would be prolonged and whether I go into torsades. I didn't have an EKG. In retrospect, I think that was a mistake. Yeah. So I would say we need the studies. They're ongoing. Give it a little bit of time. Remdesivir is an antiviral. It's a variant of an HIV drug that's meant to be an RNA-dependent RNA polymerase inhibitor. It looks like it might have activity, but it's in the midst of clinical trials right now. The company sent out, Gilead Sciences, sent out a note to providers yesterday from the president of the company saying that the studies are underway. They don't know which way it's going to go, but the company is gearing up to make this in large supplies should the trials be positive. That's going to be critical, that if we see activity of remdesivir, that could be a game changer if it works. Underscore that. If it works. It's only available IV. It's got to be given right now over a 30-minute infusion. I believe it's twice a day for 5 days. They're working on creating a slow push type of approach that might be usable as an outpatient, but that's putting the cart before the horse. At the end of the day, Bill, I think what this tells us is that we take what we have in medicine for granted so much. We have so many treatments that are available to us, and we're not used to encountering something that's this devastating, that's hitting so hard so fast, and we really don't have anything to offer. We're being forced back into the 1918 Spanish flu epidemic where they had nothing except social distancing. That's kind of where we are now.
Right.
The one thing we have...
That worked in the cities where they did it, right?
It did, absolutely. And it's working in the U.S., it's working in South Korea, it's working in Hong Kong and in Singapore. So yes, it works, but it's really hard. And it's sort of humbling, isn't it, to think that we don't have the answers right away. We do have some science that's developing, but this shows us that Mother Nature is always more powerful than we can handle at times.
Well, that's a great place to end on that note, Mike Saag. Thank you very much for your time, for your expertise, all that you put into this and other battles too. And we look forward to talking some more on this series. We'll have more about antibody testing, about other kinds of public health measures and the role of the primary care physician in all of this. So stay tuned for other videos in the series. But Mike, thanks very much for your time.
Thanks for having me, Bill.